hypertension. And the beauty is that up to a certain
As we know, all know the prevalence of hypertension is very high in patients with diabetes mellitus. Uncontrolled hypertension can worsen complication of diabetes like retinopathy, nephropathy, etc., CAD and CVA. So optimal control of blood pressure is required for decreasing risk factor. For this topic, I would like to invite Dr. A.K. Varmani, who is a general physician, diabetologist in Jamshedpur, Jharkhand.
Thank you, ma'am. And thank you, Dr. Kamlesh Tiwari, the President-elect of APICON, and the entire scientific APICON team for giving me this opportunity to talk on blood pressure target and diabetes. I request the technical team to please mute everybody. There's a lot of background noise. Technical team, yeah, please. Thank you. Okay. Hypertension is the leading cause of cardiovascular mortality. There are about 10 million deaths per year, increased strokes, heart failure, chronic kidney disease. 30 to 35% of hypertensive patients are detected to have coexisting diabetes. Similarly, the prevalence of hypertension is 1.5 to 2 times greater in patients with diabetes as compared to patients without diabetes. Coexistence of diabetes and hypertension leads to increased cardiovascular morbidity and mortality, and they form a very sinister alliance. The prevalence of diabetes in India is increasing at a very fast pace, and this is likely to also contribute to the significant burden of hypertension. Unfortunately, less than 15% of adults with hypertension worldwide have their blood pressure controlled to 140 by 90 or lower. Now, if we look at the prevalence, diabetes, we know globally 285 million individuals, prevalence of 6%, projected to go to 8%, that is 439 million in 2030. Hypertension, globally 972 million, 26%, projected to go to 29%, that is 1.56 billion by 2030, and 40 to 80% of diabetics have hypertension, and diabetics 2 times likely to develop hypertension. And look at the various microvascular heart and complications, the peripheral vascular brain, etc. I'm not going to go into the details. And it is also seen that hypertensives are 2.5 times more likely to develop diabetes within 5 years. And if you look at the Indian scenario, it is world capitals of diabetes. Every fifth person of India is a diabetic. 171 million in 2000 to 366 million by 2030, and soon we are on the way to becoming the hypertensive capital. One out of every three persons is hypertensive. Twofold increase in hypertensive population from 594 million in 75 to 1.13 billion in 2015, and now we are 6 years ahead. So one out of every two diabetics is hypertensive. Now, which part of the blood pressure we are talking about? If you look at CV mortality risk doubles with each 20 systolic increase of blood pressure increment. So it is the systolic blood pressure which is a stronger predictor of risk than diastolic blood pressure as far as cardiovascular disease and diabetic nephropathy is concerned. Now, 65% of the diabetic hypertensives have isolated systolic hypertension, and we know that treating systolic hypertension per se is very difficult, and it becomes a big challenge to control systolic hypertension. If you look at the categories, there are a lot of variations. The American Heart Association and the American College of Cardiology in 2017 came out with guidelines. Then the European Society of Cardiology, European Society of Hypertension 2018 came out with guidelines. And if you look at the normal by the Americans was less than 120 by 80, but by the Europeans was between 120 to 129 and 80 to 84. The grade 1 hypertension was 140 to 159 and 90 to 99 by the Europeans, and it was stricter 130 to 139 and 80 to 89. And isolated systolic hypertension was a systolic of more than 140 with a diastolic of less than 90. Despite these differences in the grading of blood pressure, if you look at the target goals, both of the European countries across the continent agree that in patients with diabetes, we must get the blood pressure down to less than 130 by 80. And to just to give you a summary, one must remember the threshold for treatment is 140 by 90 in patients till 65, almost 79 years, and it is the one systolic should be 160 in patients more than 80 years. And if you are looking at the target goal, it is 130 by 80 usually, and in more than 65 years, we can keep the systolic between 130 to 139, but never bring down the systolic to less than 120 and diastolic less than 70. And the Indian guidelines also published in the JAPI 2019 somehow favor the same thing, the threshold being 140 by 90 and the target being around 130 by 80. And if you look at the risk, if, if you're looking at secondary prevention of recurrent cardiovascular events in patient with clinical CVD, then 130 by 80 target is where we would like to keep the blood pressure. But if you're looking at primary prevention adults, then you have to look at the 10-year ACVD risk of 10% or higher, again 130 by 80. But if you're looking at primary prevention with no history of CVD and an estimated 10-year risk of less than 10%, then 140 by 90 may be sufficient. And the treatment, of course, in patients with diabetes is again less than 130 by 80. Now, it is very important, and the European Society for once did a wonderful job of talking about the total global burden risk of the hypertension. And they put it according to the grade of the hypertension and the stages being the presence of various risk factors. And if you see, if there's diabetes with hypertension, it is already moderate to high risk at a blood pressure of 130 or 85, more than that, and then becomes high risk. But if there is diabetes with organ damage, no matter what the blood pressure, it is very high risk. And if they have mentioned that you should initiate treatment with a RAS blocker plus CCB or a thiazide or thiazide-like diuretic, do not use AC and ARBs together. But it is the first time that an international guideline also looked at the Asians and said that the Southern Asia has 1.4, 40% more risk as compared to the Caucasians. And why is it? Are we Asians different? Let's look at it. Phenotypes of CVD, stroke, heart failure, which are closely associated with blood pressure, are more common in Asia. Association between hypertension and CVD is stronger in Asian countries than Western countries and occurs at an earlier age. Stroke is more common than coronary artery disease in the Asian population, whereas the coronary artery disease is more common than stroke in the Western population, as shown by the honest study, 2.8 times higher. The slope of association between higher BP levels and CV events has shown to be steeper in Asians. We are more likely to develop higher blood pressure even with mild obesity, more likely to have morning surge, nocturnal hypertension, greater BP variability as compared to the Western population. And moreover, we have a genetic predisposition to salt sensitivity, compounded by high salt intake as well as a significant seasonal variation in BP. But these are not just statements, we have evidence. And if you look at the Mumbai India cohort study, if the blood pressure jumped over 130, there was a huge jump as far as cardiovascular death, cerebrovascular accidents are concerned, and a nominal increase in the ischemic heart disease. So antihypertensive medication targeting a lower BP, systolic BP of less than 130 would be of greater benefit in Asians than in Westerners, especially if you want to reduce stroke and heart failure. Now, this is a systemic review, and this is the old UKPDS study where it showed that by treating blood pressure in patients with diabetes, there was a significant reduction of 24% in diabetes-related endpoints, 32% in deaths, 44% in strokes, and 37% in microvascular endpoints. And a meta-analysis has shown that if you bring the blood pressure to less than 140 by 90, look at the immense benefit 27% reduction in stroke, 17% in albuminuria, 12% in CSD, etc. Now, when you come to the glucose control, tight glucose control, and tight blood pressure control, if you look at this, we know that intensive glucose control can reduce stroke, diabetes endpoint, diabetes death, and microvascular complications. But if you have tight blood pressure control, look at the benefits, the immense benefits on stroke, the various endpoints, and the microvascular complications. Now, this was a wonderful study which studied the difference between intensive blood pressure control in patients who were on intensive glycemic control and conventional glycemic control. And they looked at the first cardiovascular event, and the patients were almost divided into 2,300 for the standard glycemic and 2,370 for the intensive. Follow was 4.5 years. And what was the conclusion? The CV event risk in patients receiving standard glycemic control was significantly lower in the intensive BP treatment group than in the standard BP treatment group. And whereas patients receiving intensive glycemic control did not differ between the two groups. So it is more important to control blood pressure than to control blood glucose given an option. But of course, you should control both. But today, the question is how aggressively BP should be treated in patients with diabetes to protect cardiovascular and renal disease. In diabetes is lower better when it comes to BP. Now, in this wonderful study, bringing systolic to less than 110 was more, these patients were more likely to die than those who had a systolic between 130 to 139, almost 2.8 times. And a diastolic of less than 74 was also significantly associated with an increased mortality. So, in patients with type 2 diabetes whose blood pressure was less than 110 by 75, they had excess mortality at 3.5 years. So, definitely, too much low blood pressure is also not good. Now, I'll show you two wonderful studies. What is the effect of antihypertensive treatment at different blood pressure levels? And one was published in the PMJ in 2016, 49 trials, more than 73,000 patients. If the BP is greater than 150 and you bring it down, you reduce the risk of all-cause mortality, cardiovascular mortality, MI, stroke, and end-stage renal disease. But if you bring it down, the BP is 140 by 50, you reduce it, you have additional benefits of the mortality reduction. But when you bring the blood pressure down to less than 140, then there is increase in the risk of CV mortality with a tendency towards an increase in the risk of all-cause mortality. Now, this was a general group of patients, mixed group, who also had coronary artery disease. And we have a second paper published simultaneously in patients with type 2 diabetes, but no previous cardiovascular disease. In more than 187,000 patients, less than 75 years, no history of CVD, follow-up 5 years. And they saw that if you maintain the systolic between 110 to 119, they had significantly lower risk for non-fatal AMI, total MI, non-fatal stroke, CVD, total CVD, CSD, etc., as compared to the systolic of 130 to 139. But having said that, there was an increased risk for heart failure and all-cause mortality at that particular blood pressure level. So what the message? The baseline systolic BP of less than 130 conferred significantly lower risk for adverse CV events than the systolic BP of 130 to 139, which is the correct target. It also suggests that the association between low baseline systolic BP and all-cause death is not due to primarily CV disease, but rather due to concomitant disease or patient factors that lead to both low BP and excessive risk. So is there a J curve? And that is what the Clarify study said. J curve means that cardiac events increase at lower BP targets. If the BP is more than 140 by 90, we know there is increased risk of events. If the BP is less than 120 by 70, Again, we know now that there's increased CV death, MI, all-cause death, hospital admissions for heart failure, but not for stroke. Now, there have been number of trials which have denied and number of trials which have supported this hypothesis. But the message that I want you to carry home is that this is applicable to patients with hypertension and coronary artery disease only. But unfortunately, what happens then in patients with diabetes and elevated CV risk, even after extensive adjustment for underlying disease burden, there is a persistent association for low diastolic blood pressure with subclinical myocardial injury and the risk of myocardial infarction. So one should not go down too low. The available evidence from the RCTs suggests that in patients with pre-existing cardiovascular disease, especially CSD, it is prudent not to lower the blood systolic to less than 130. However, those who are at a higher risk of stroke, such as the Black and Asian patients who do not have pre-existing CSD, it may be beneficial to reduce systolic to less than 120 if this can be done without any harm to the patient. What about kidney disease? They say the lower target, especially if there's proteinuria, should be less than 125 by 75. Of course, there were conflicting studies done, but the current recommendation of 2021 KDIGO guidelines say maintain a systolic of less than 120 by 80 and use the RAS blockers. And it was shown that if you follow this guideline, almost 70% of US adults with CKD are eligible for BP lowering. And among those with albuminuria, 78% eligible. But unfortunately, only 39% are taking RAS blockers. So what should we be doing? We should be taking decisions beyond guidelines. I think it's time to move beyond dueling hypertension guidelines, derived largely from clinical trials that excluded many patients because of age, comorbid conditions, and social determinants of health, to a more nuanced, personalized approach based on agreed scientific and ethical principles that can be readily implemented in clinical practice. Despite the recent guidelines, we should continue to treat patients and not millimeters of mercury. And these are the recommendations from the International Society of Hypertension, which I firmly believe in, that in patients with diabetes or without diabetes, it is good to have a blood pressure of less than 130. But those who are having 130 to 139 should receive severe lifestyle or intensive lifestyle modification. And only when resources allow and for those at high CV rates should drug therapy be considered. In patients, regardless of CVD risk score, if we cannot achieve less than 130 by 80 in 6 months of appropriate lifestyle therapy, we must start drug therapy. And in patients less than 48 years with a systolic more than 120, family history of hypertension, diabetes, or dyslipidemia, we must attain a goal of 120 by 80 or less than that. If it is not achieved after 6 months of appropriate lifestyle therapy, we must start drug therapy. So, what are the take home messages? Diabetes and hypertension form a sinister alliance. Hypertension is a very strong, modifiable risk factor for the macrovascular and microvascular complications of diabetes. The diagnostic cutoffs of blood pressure and target levels will always remain controversial. Tomorrow we may have some other targets. But a key cautionary note about appropriate BP targets is that the majority of patients with hypertension are not optimally treated, and even using thresholds higher than those that are currently being debated. So, from a population health perspective, more would be gained from maintaining traditional BP targets for the entire population, perhaps adjusted for age, while sorting out the nuances of who might benefit from tighter blood pressure control. In the age of precision medicine, when we are sequencing genes to personalize medical care, something as simple as BP still being viewed as a one size fits all is totally illogical and bizarre. So treatment has to be individualized to the specific patient based on their comorbidities, their anticipated benefit for reduction in atherosclerotic cardiovascular disease, heart failure, progression of diabetic kidney disease, retinopathy, and risk of adverse events. And this conversation should be a part of shared decision making process between the clinician and individual patient, acknowledging that the benefits and risk of intensive blood pressure targets are uncertain and may vary across patients. So the target blood pressure is less than 140 by 90, preferably less than 130 by 80 in Asians. However, lower targets of 120 to 30 may be achieved if patient can tolerate. But the message is keep the systolic between 120 and 40, diastolic between 70 and 90. Thank you very much for patient here. Chairpersons.